Thank you, Terry. Hi, everyone. So I am Siqin I'm an assistant professor of medicine at Columbia, general cardiologist by training. I'm also the associate chief medical officer for Columbia Doctors, our faculty practice, and one of our leads for telemedicine expansion. So I'm happy to join everyone today and talk a little about the landscape of telemedicine in the time of COVID-19 pandemic and beyond as well. So I don't have any conflicts of interest. So the major topics we'll cover today are the state of telemedicine in the U.S. prior to the COVID-19 pandemic. We'll talk a little bit about what happened with telemedicine expansion during the COVID-19 pandemic. What are some of the key regulatory changes that allowed the expansion to take place? What's the practice landscape for telemedicine during the pandemic? And some of the earlier findings that are emerging for the outcomes of changing a lot of our healthcare delivery to telemedicine, and some potential concerns as well, especially with regards to quality of care and disparities. And then I'll talk a little bit more about the future direction for telemedicine as the pandemic ends, hopefully in the next few months, and as we look towards the future. So before we get started, I just wanted to talk about the terminology. I like this overview that was in a review by HRQ published last year that really sort of defines the different concepts. So here they make a note that e-health really is a very broad category, covers everything from something like a digital intervention that's delivered in the office, and then telehealth is something that covers preventive, promotive, and curative healthcare delivered over a distance. So something like shared decision making with the patient, done at home remotely through a digital device or app, that falls on care telehealth. And when we talk about telemedicine, it's really talking about curative healthcare services, treatment that's done over a distance, things like teleradiology, telepsychiatry, teledermatology, and really a lot of the telespecialty care that we sort of routinely talk about as telemedicine. So it's this latter category that I'm going to focus on today. So where was telemedicine prior to the pandemic? So really there has been a big increase in telemedicine over the past 20 years, partly as technology have evolved in terms of Skyping, video conferencing. But I think as with many things in healthcare landscape, we probably lags behind in innovation and technology, especially in this tech space. So even as video conferencing technology has evolved, telemedicine was really slowly catching up. Part of the barrier is that the regulatory and payer landscape is incredibly fragmented. The biggest payer, I think, out there, Medicare, and they historically prioritized telemedicine as a way to expand access for things like rural hospitals where patients have difficulty accessing specialized services or maybe understaffed, for example, in the ICU. So a lot of the Medicare telemedicine coverage rules historically has been focused in that setting with different kinds of models for tele-ICU, where the patient's in rural hospital ICU, but the staffing is done by a teleintensivist sitting at an academic medical center somewhere. Or they also have models where the patient comes to the hospital, to an emergency room, they need a specialist service at the rural hospital that's available, then they have a video conference with a specialist that's sort of staffed remotely. The one sort of exception is really telestroke, where CMS, using the FAST Act that was passed in 2018, they covered telestroke service broadly, mainly as a way to quickly connect, say, a paramedic who's taking care of a stroke patient with a neurologist or a stroke specialist at a medical center that may be in the same city as a way to make some quick treatment decisions. And then the state policies also really vary, but over time, most of the states, about 2/3 nowadays, has mandated coverage for telemedicine, really to say that telemedicine should be paid, sort of be reimbursed by the payers, and often at a similar rates as if the visit would happen in person. So as an example, I'm from New York. A lot of our work was sort of enabled by the fact that in 2015, New York State passed legislation to require telemedicine parity, which means that telemedicine service should be paid at the same rate as in person. Even then, I think because the state only regulates certain payer plans more closely, so we have a situation where a lot of the employers self-funded plans, they have discretion, and it's sometimes very complicated negotiation to get them to cover telemedicine services. The one other area that's sort of a major barrier for telemedicine uptake is that the licensure requirement for out-of-state patients is still governed at state level. So typically, states require that the patient has to be in a state where the provider is licensed to be able to offer telemedicine service. So for New York, for example, historically we have said, our provider for license in New York can see New York patients over telemedicine, but we cannot do it for New Jersey, Connecticut. Even so, we do see a lot of those patients in person, partly because of the state licensure requirement. So given all this, we do have, over the past 20 years, or really over the past 10 years, a number of sort of telemedicine vendors that emerged, and you're probably familiar with some of these names: American Well, Teladoc, MD Live, Doctors on Demand, and they do a variety of, telemedicine, urgent care, specialist consults type of models, and that was a growing, space before the pandemic hit. So some of the data out there about the increase in telemedicine service across the past 2 decades, this is from Optum data that was published in JAMA 2018. They showed that a rapid increase in telemedicine primary care and mental health visits, especially since 2015. I think partly that was when they began to really roll out telemedicine service for a lot of the practices that were owned by Optum. So you can see that the takeoff was pretty rapid because it was very convenient for patients. But however, if you look at the blue line, you can notice that despite these large increases for other specialist consult, it's a much slower uptake, and that's in general I think is a sort of experience that's shared by many other institutions as well. The one interesting thing to note from that paper is that there are state and system factors for different kinds of services. So in this case, the psychiatry telemedicine uptake, as it was increasing, it was impacted by whether the state covered psychiatry services at parity, and also if the state had a sufficient psychiatry supply. Places where there's an undersupply of psychiatrists tend to see more telemedicine visit. So some of this are, these practice patterns is driven by, sort of the supply-demand factors as well. This is data from Kaiser Permanente, who, and this is sort of a very interesting implementation they did in 2016. They started to have direct scheduling for patient through, I think through Epic or the patient portal. They allow patients to choose if they want an in-person visit for primary care versus a telemedicine visit versus I think a telephone visit as well. So you can see that when you enable this for patients and give them the choice, 14% of the time the patient chose telemedicine. The flip side is really the majority of patients, I think, still preferred in-person visits, but there are some factors that drive telemedicine use. So younger patients, those who are 18 to 44 years old, patients with higher deductibles or more travel time, or if they didn't have a paid parking garage, those are driving telemedicine use as well. And not surprisingly, residents who had residential areas that had better internet access are more likely to have higher telemedicine usage. Patients in general are more comfortable with their having telemedicine visit with their own PCPs, I think, which is understandable because I think people are still reluctant to have telemedicine visit with someone that's new they don't know. They did show that patients who are Black and Asian race are more likely to use telemedicine visits, but I think there are also some factors because this is a commercially insured population. So there's some sort of sampling skew to this, and we'll show a little bit data on our current understanding of sort of ratio and other disparities that are some of the challenges we face right now. So with all this, telemedicine is sort of projected to increase, throughout the years. This is a Polaris market research data that they, published using 2019 data and historical data. Really, they released this in 2020, although obviously the landscape has shifted radically this year. So you can see that, even before the COVID-19 pandemic, the telemedicine market size was projected to continue to increase really throughout the next decade, really across all service areas: radiology, psychiatry, stroke, tele-ICU, teleconsultation. So this was something that was coming anyway. But really what happened with COVID is that I think it pushed a lot of this probably by at least a decade in terms of telemedicine adaptation. And I think I'm going to some of the details here where telemedicine usage really increased at a pretty unprecedented pace across the U.S. healthcare system. It's a very dramatic transformation for how we deliver care, really across the space of several months. There are a number of factors. The most obvious ones are the necessity of social distancing, infection control. Patients, I think, have a lot of concerns for coming into the office, especially early during the pandemic, during the spring of 2020. The patients really wanted telemedicine, and they're more amenable to sort of navigate technology to allow telemedicine to happen. I mean, some instances like New York, and certainly in New York City, at that point, really the major way to access care was through telemedicine because a lot of the in-person practice was shut down by that point as well. Then I think this was also enabled by a series of very quick legislative and regulatory updates by CMS, the states, and commercial payers. They essentially allow a lot more flexibility in what technology can be used, where the originating site could be, and there's a slew of waivers for regulatory requirements. And the states and other payers really has made a lot of big steps towards guaranteeing telemedicine payment parity. And actually, during the COVID-19 pandemic, the payers, a lot of them recognized the fact that patients didn't come in or wasn't safe to come in. So they actually put in place a series of copay and coinsurance waivers that in some ways probably actually advantage telemedicine visits more so than in-person visits from a financial perspective for patients. So some of the key regulatory changes and that happened early in the pandemic, and some of you may be familiar with this already, but beginning in March 2020, Medicare announced a series of waivers for telemedicine under the umbrella of public health emergency. And again, I think the most important one is probably the waiving of the originating site requirement, really that the patients can now be anywhere and have a telemedicine visit. They can be at home. I have done telemedicine visit where the patient's in a car, someone else is driving. So it become very flexible. And then CMS actually did a very interesting thing. They said the HIPAA rules are still in place, but they will waive enforcement, meaning that now they're allowing a lot of flexibility in terms of telemedicine platforms that can be used. So this is how people started using FaceTime, WeChat, any of these number of platforms for telemedicine visit, and sometimes partly because that's what patients are used to. A grandmother who doesn't use a lot of technology, they still use FaceTime to FaceTime with their grandkids, so they can use that for their telemedicine visit for their PCP, whereas they would have struggled with the technology to be used to sign in through the patient portal. But during this time, we also had other platforms emerge out of more HIPAA compliant. I think Zoom sort of became a major player, even as it became a major video conferencing player for business needs as well. Doximity, which probably many of you are familiar with, quickly jumped into this space. They created a very easy to use platform where essentially it's a video dialer that's sort of embedded into the Doximity app. And I think just because how easy it was to use, it quickly was able to get a lot of the market share as well. In general, the CMS do recommend that if an unsecured platform such as FaceTime or WeChat is used, you should tell the patient that there are some privacy and security risks. But again, during the public health emergency, that HIPAA requirement is not enforced. And similarly, I think Medicare said that they will guarantee payment parity for telemedicine services. That's sort of true historically as well, because the Medicare rates for sort of covered telemedicine service are largely the same as if they're in person. What they did was actually they did one step further. They made some sort of a little bit confusing changes in terms of how you bill for telemedicine service with modifiers. That's to be used with the idea that if you want, they didn't want people to be underpaid if, for example, there's facility payment fees associated with the visit. So they sort of relooked through those angles to make sure that the practices that are hospital outpatient based can be paid the same. And then CMS actually did a couple of rounds where they actually looked over the CPT codes and expanded them to be eligible for a telemedicine service. It essentially defines them as telemedicine eligible services. One of the major things they did was they did add some codes specifically for telephone visits. Although in general, throughout all this and even now, they still view telephone as something that's fundamentally different than video face-to-face visit, and I think they're still struggling with how to better codify that. And I'll talk a little bit more later on about, I think, the Medicare population really do, I think, a lot of times struggle with the video technology and do rely on telephone to maintain that continuity in care. The one thing that I'll sort of call for, for nephrologists, who are in the audience here is that as part of all this, the CMS did sort of liberalize what's required for the monthly face-to-face visit requirement for outpatient dialysis services, including allowing the monthly face-to-face visit requirement to be done over video technology as well. So most of you probably are familiar with this doing your practice. So what does the state and the commercial payer do? Again, they sort of largely adopted similar stances. They guarantee payment parity for telemedicine services. And then even for the non-COVID visits, in the spring and summer, they really waived the copay and co-insurance for patients, so the patient had less out-of-pocket costs for telemedicine service. And in some ways, this actually placed telemedicine a little bit more advantageous for patients compared to in-person visits. The one other thing that the states did was that they required telemedicine, they relaxed telemedicine licensure requirements. If you look at the language and some Medicare waivers, Medicare always tend to say that they allow telemedicine service across state lines for its beneficiaries during the public health emergency. But the reality is that the licensure requirements typically governed by state, and the state have individual policies, and it's still a little bit patchwork. But in general, I think all states have taken the stance that for patients with established relationship, they can be followed by their providers out of state if there was an established relationship with the patient. Typically, depending on the state, they have more restrictions for new patients being seen by telemedicine across state lines. Some of the states also created temporary licensure mechanism for telehealth. So again, because I'm from New York, we encourage our providers to take advantage of the New Jersey, Florida mechanism, where you can essentially register online, pay a very nominal fee like $50, and be a temporary licensed telehealth provider for patients in those states, which gets around with some of the new patient issues. So where were we at, in spring? So this is a summary from the Commonwealth Fund that was published, I think, in May. Really sort of describes some of the early changes in the telemedicine landscape. So you can see that, in March, a very, very low portion of telemedicine visits sort of done across the nation, essentially 0%. But once the pandemic hit, once the practice started shutting down for in-person elective visits, telemedicine really took off. They compared the volume compared to the 2019 baseline in the same weeks. So for example, in April, you can see that up to 14% of the telemedicine visits were the proportion telemedicine visits is about 14% compared to the 2019 baseline. In reality, at that point, the in-person visit actually dropped precipitously as well. So the proportion of telemedicine visit as a total visit during that time period is actually close to half at that point in time. And then, since then, the telemedicine visit sort of trended down a little bit, where the in-person visit volume, recovered a little bit. So I'll talk a little bit about our experience at Columbia, and which I hope will provide some guidance as people think about their own telemedicine expansion work. We sort of had experience in 2018 to 2019 using the American Well platform. We, at some point towards the end of 2019, we were reaching about 250 telemedicine visit a month using American Well. And then we switched to Epic on February 1st with the idea that we would slowly, resume our telemedicine services using the Epic integrated video visit process. We used a product called Video back then. Now we're using Zoom. That's integrated with Epic. We sort of chose that because it really allows better implementation at scale, because we can, make some quick tweaks. And that really actually stood us well when the pandemic started. We actually gone through a quick process at the beginning of the pandemic over a period of probably 2 weeks or so, where we quickly reconfigured our, Epic video visit so that all departments can schedule patients for video visits. All the providers are enabled to do so. We did a lot of work to increase our bandwidth and server capacity. I think our server capacity was doubling like every week for like 2 or 3 weeks. We actually quickly provisioned iPads to a lot of providers, because back then the provider didn't need to use an iOS device to do this. We've done a lot of education and outreach, creating standardized guides and webinars for the providers, and also to a lot of patient outreach work to really sort of teach them the process. We actually, relied a lot on volunteers, including medical students, nursing students, and we try to support our patients as much as possible, through text, email, mass portal messages, to try to get them signed for the portal and to learn the telemedicine process. And I would say even with all that, I think it was still a big learning curve. And because I think it is, a very sudden and big culture change for providers and a big change for patients to suddenly have to negotiate a lot of technology. Before there was a choice, I think during the pandemic, again, unfortunately, there wasn't a choice when a lot of the in-person surveys were closed down. But overall, I think we are very successful. And I think this is pretty similar to the experience at a lot of other academic medical centers and a lot of large practices as well. You can see that, over March, that we sort of gradually expanded telemedicine visit from really several hundred in February and the beginning of March to its peak about, 14,000 a week, with 10,000 being video visits. I showed the second figure to demonstrate that I think this can be a model really across the specialties. We know that for procedure specialty, things like ophthalmology, urology, telemedicine is harder in the sense that a lot of requirements for the clinical care cannot occur over the video. The way we implement this, I think a lot of this is telemedicine was really used as a triage process. So if you have an acute issue, if you sort of didn't need, go to the ED, you can actually you can actually connect with your ophthalmologist for the initial sort of evaluation and intake, and then determine if you need to come in person. So telemedicine sort of allows to building that triage process, and we're able to leverage that across really OR specialties. So I sort of show a little bit that we can quickly expand telemedicine services, and this is what happened, during the spring and summer. I think some of the questions that naturally arise is, are patients satisfied? Does telemedicine expansion impact clinical care? And how does it impact access and disparities? I think, for patient experience and satisfaction, I think the data is more clear. In general, patients who were able to access telemedicine services had positive experiences. And this was true both before and during the COVID-19 pandemic. One obvious difference is that, before the COVID-19 pandemic, this was really largely by choice. While during the COVID-19 pandemic, I think there's a component where patients were their only access to care was via telemedicine, which changed the dynamic somewhat. And then, for impact on clinical care, I think there's a lot of questions now emerging that are there gaps in care that's delivered telemedicine? Are we going to have similar clinical outcomes, or does telemedicine, when we sort of use it to replace in-person care, does that lead to worse outcome? I think that is an area of major concern. We do have some early evidence to show areas where this could be a problem. And then finally, I think this is a very important point, is that as we change telemedicine from something that patients can choose to something that's really sort of a routine part of healthcare delivery, and in some, at some points during the pandemic, the only way to access care, how much do we exacerbate what I call technology-driven disparities, meaning that the potential disparities actually introduced because different patient populations have different access to technology and different levels of digital technology literacy. I'll try to go over some of these points. This is data, again, from the Kaiser group that came out in 2019. They surveyed several thousand patients as part of their telemedicine expansion visit, the sort of the patient choosing whether they want to see in person versus video. And afterwards, a bunch of them were asked to complete the survey, and then several thousand responded. So you can see in general, patients are pretty happy with their telemedicine experience. More than 90% felt that their video visits adequately address their needs, that their providers are familiar with them, and they feel confident about the quality of care delivered. And 80% feel they actually improve their relationship with the provider. They still identify some challenges. 40% said they prefer to get in-person care. 24% was concerned about how to prepare themselves for the visit. And then 20% still felt they might not get adequate treatment. Privacy, I think, the privacy concern comes up time and again. I periodically get some feedback on this, but overall, it hasn't seemed to be a major issue. Back to only 10% had that concern. And then, during the COVID-19 pandemic, I think the experience is largely very similar. This is a survey of 1,000 patients that was done, again, by a marketing research firm, Kairos Inc. They surveyed about 1,000 patients. They find that overall patients were satisfied, 40% were completely satisfied, 37 were very satisfied, and 90% was somewhat satisfied. So in general, most patients are satisfied with the care received. They feel that the telemedicine care was convenient. It gave them safety to be able to receive this care at home during the height of the pandemic. And also improved speed of access, because I think a lot of times then this is true that it's very easy to schedule patients as an add-on or telemedicine visit, and it's probably a little more convenient to do so than in-person visit. There are some concerns about quality of care received. There are some concerns that, the telemedicine video visit experience is probably a little bit more impersonal. A technical issue, I think, still comes up, and it's not something that I think we can literally solve 100% of the time, but it's something that I think that we still continue to need to address. So going into sort of the quality of care aspect a little bit. So I just wanted to sort of reiterate that, prior to COVID-19 expansion, the use case for telemedicine were really sort of very select. They're used as a way to expand access in areas that really did not have adequate access. So in general, when you have these targeted telemedicine efforts, they had good outcome. So this is data from the HRQ review in 2019 that summarized a lot of these prior telemedicine use cases. The remote intensive care units, for example, have been shown to reduce the ICU hospital mortality, which makes sense because you're essentially having more trained intensivists being able to remote into the rural hospitals that are understaffed. And then when you look at the remote specialty care consult, it showed that they do reduce wait time, to reduce the travel time for patients. And in some clinical areas, it does improve outcomes such as wound care, response to psychiatric treatment, and being better at managing chronic conditions. Again, I think this is a testament to the fact that when we use telemedicine rightly, it can expand access and lead to improved clinical outcomes. But I think one concern again with the pandemic is that telemedicine is now used as a substitute for in-person visit for a variety of reasons. And what comes up time and time again is that in telemedicine often we don't do physical exam the same way. You can listen to the patient. And you can ask patients to, do things like, move their arm around if they have the pain. There's some cool studies where you can, for example, assess a JVD through telemedicine that came out. But in general, I think there is a concern that we lack some of the physical exam details and vitals that can drive decision making. I think another concern is that when patients coming for in-person, if they need lab or a test, and sometimes do it, need it urgently, they can do that by going to the front desk, getting everything scheduled and taken care of, and go down to the lab or get the blood draw in the office. For telemedicine, we really need to think through how that might be arranged and how to, arrange patients to go to sort of a remote laboratory, the Quest, or for us, one of the patient service centers that we set up. So a lot of those has to be thought out. And really, I think there's still a lot of unknown in terms of how much do we alter the quality of patient communication when things are primarily done over video, because I think we do miss things like body language, having an opportunity to sort of ask patient and family to sort of reverbalize their understanding, which is sometimes a little bit less natural in a video setting. I think the one aspect I think that's superior is that you do get the patient, you're able to enter the patient's home, and sometimes that can also get some information to understand their home environment, that which sometimes can drive the patient care as well. So some of the findings that are just coming out on this. This is a publication that came out, I think, in August, where they looked at a large claims database that aggregated millions and millions of outpatient visits. They were comparing some of the content of the visit that occurred between 2018 to 2020. So they show that, for example, for primary care visits in 2020 Q1 and Q2, how often the blood pressure was recorded really sort of decreased dramatically, and how often the cholesterol was recorded decreased dramatically as well. The reason, and we look into this reason mainly, is that because there's so much telemedicine visits happening in Q1 and Q2 of 2020 compared to the in-person visit. So for example, in Q2 of 2020, 70% in-person visit had BP recorded, but only 10% of telemedicine visit had a blood pressure recorded. And because there were so many telemedicine visits, that sort of drove down the overall rate of blood pressure being recorded. And similarly, for cholesterol assessment, 21% in-person visit was able to assess cholesterol by getting a lab done, whereas only 13% for telemedicine visit. So I think it's not surprising when we convert a lot of these primary care to telemedicine, we take care of the acute issues, but some of the things like getting the blood pressure done, getting a cholesterol done, getting some of the preventive tests scheduled for, I think they do take a hit. And some of our own work right now, I think, is to sort of set up better process to remind patients to, check their blood pressure using the home monitor, and then have the physician record it, so at least we can make sure we kind of keep an eye on this. Again, this is an area I think we just need to pay close attention to, because I think long term it could adversely impact, cardiovascular disease risk management and really other aspects of their care. So I'm going to talk a little bit about the disparity issue. So as I sort of mentioned, a lot of the prior telemedicine use cases prior to the COVID-19 pandemic were really designed to improve access and to reduce disparities, and they were explicitly set up in that way. But now when we are converting to telemedicine en masse, and telemedicine often becomes the only or the main way to access care, there is a big concern that disparities can be exacerbated because vulnerable patient populations may lack the technology, or they don't have the technology literacy to navigate all the steps that are required. There's a New England Journal Catalyst article that sort of lays out a lot of this aspect, right? Because I think when we talk about telemedicine, there are really a number of prerequisites. Patients need to have access to broadband internet. They need to have smartphones or computers that have a web camera and a speaker. They have to have the health literacy and the digital technology literacy to be able to use their computer or smartphone to open up the patient portal, launch the visit, or open up a Zoom app to launch the visit. I think language barrier is a big issue as well. We actually realized, I think in the spring as we were transitioning to Epic, that one big limitation we had was a lot of our information in the portal were English language only, and over the summer we had to do a quick task to really catch up on a lot of translation to better serve our Spanish-speaking patients. But again, there's so many medical terms in the portal that are still not translated, and I think that still remains a barrier. And I think there are health system level factors such as who is offered a video visit. For example, I think a clinic that serves a lot of patients who are not used to video visit may be naturally less likely to offer them. We do see that in our system, where I think even some of the places where we know some patients can do video visits are not offered it because the clinic are not used to it. And then things like how we set up, interpreter services and how we integrate them with our video visit process to make it easier for the patient. I think all these can sort of lead to disparities as well. I think as we quickly transformed a lot of our practice to telemedicine, some of these issues were also quickly recognized as well. There's a sort of two research report that came out in the same issue of JAMA Internal Medicine, I think in August, that really sort of showed the challenges that elderly adults face. So the first one, which I show a figure here, is that many elderly adults sort of have reasons for unreadiness for telemedicine visits. Up to 38% may be quote unquote unready for video visits, whereas 20% may be unready for telephone visits. Partly because a lot of them are not familiar with technology. This is based on survey data. A lot of elderly adults, 24%, have not had email or texted or gone online in a month because they are not part of the internet landscape. They are not frequent users of technology. And then many of them also have challenges such as difficult hearing, difficult communicating, dementia, vision challenges. And so some of that disability also would naturally affect their ability to use telemedicine. And then the second research letter by Roberts, et cetera, they looked at, based on survey data, again, how many elderly adults lack digital access, meaning a computer with high-speed internet, and smartphone with data plan. And they showed that, again, this is very common in elderly adults. About 26% of them lack digital access. And then really the impact is kind of disproportionate for the vulnerable patient populations, those who are very elderly, and then Hispanics and Black patients also are more likely to lack digital access. Elderly patients who have low household income or in Medicaid or are dual eligible, or has disability, also more likely to lack digital access as well. So I think this is something that Medicare also recognizes, and this is part of why they have initially decided to expand coverage of telephone service and are still trying to figure out how to codify that. So we did some of our own evaluation as well. So in March and April, our care was delivered mainly through telemedicine across our outpatient clinics. We encourage everybody to use audio video visits, but again, recognizing how often that patient may struggle with technology, we did allow telephone visits as well. So we sort of hypothesized that this would be a natural experiment, because I think sort of the vulnerable patient groups will be less likely to access telemedicine via audio video technology, but will be more likely to use telephone visit. So we analyzed 80,000 telemedicine visits from 50,000 unique patients from those 3 months to really try to figure out who are using audio video and who are using telephone. And to see whether that can help us understand a little bit the sort of the disparity issues that are driving technology use. So this is what we find. We find that patients who are elderly, not surprisingly, are much less likely to use video technology for the telemedicine services. The odds ratio for patients 65 and above was 0.18. So again, it's a very challenging for that patient population to use video technology for telemedicine. We find that Black patients and Hispanic patients, or people who primarily speak Spanish, are less likely to use video technology and more likely to use telephone. And again, for patients who are Medicare or Medicare insured, it's a challenge as well. So I think we were a little bit surprised to find such dramatic effects, but on the ground, this is what we observe. So we do have the technology available. Many patients struggle with taking advantage of those, and I think it does create disparity issues. And I think, in fact, we have moved quickly to restore in-person services at some of our, more vulnerable patients clinics that see sort of more vulnerable patients, Medicaid patients, to make sure they continue to have access to care. And the other things we do is to really sort of double down on the patient support in terms of creating patient ambassador service to help them navigate technology, creating more easy-to-use patient guides, and looking to, for example, other mechanisms to provision patients with broadband internet access for those that really need them, as a way to prepare towards the next phase of the pandemic. We see this, sort of similar findings are seen at other academic medical centers as well. This is a publication from Penn that look at several thousand cardiology clinic patients. Again, sort of the similar issues of age comes up in their sample. Female patients also tend to have more difficulty accessing telemedicine services. And interestingly, they linked this to zip code median household income, and they see that the lower median household income zip codes is associated with more telephone use compared to video. Probably, again, has to do with access to technology and to internet access. This actually just came out in early November. This is data from Optum with 6 million visits that really sort of shows the patterns of usage for services across a pandemic. And what they do show is that if you look at zip codes that are more than 80% white compared to 20 to 79% white compared to those that are primarily non-white, you do see different patterns of utilization for in-person and office-based visit. While the in-person visits sort of reduced more for the zip codes that are higher income and are white, those sort of wealthier, higher socioeconomic zip codes were more able to sort of make it up by telemedicine visits, whereas for the sort of the zip code with lower income or more non-white population, they had less in-person based reduction, but also lower telemedicine visit use. Again, suggesting that more vulnerable populations have more difficulties, converting to telemedicine usage. I think what's interesting is that you can look at the vaccination rate. There's less reduction, for example, in some ways for the for the lower income neighborhoods and for the greater than 80% non-white neighborhoods. Partly because is that I think when you have more in-person visits, you are more likely to get the appropriate vaccination. So in some ways, there's this complex interplay between the challenges of technology access and being able to access telemedicine service, but also maintaining some of the quality of care, such as vaccination, that are probably still better done through in-person service as well. So there's an interplay between access and quality here that I think we still need to get more evidence for, and I'm sure a lot of research is being done in this area will come out in the next year or so. I want to finish this part by sort of focusing on sort of on a model to really think through how we better engage patients in virtual care. This is the model that we are looking at Columbia as well. This came from Stanford. I think the major point here is that we often think of the virtual visit experience as that big circle in the red in the center. What happens, during the virtual visit when the provider signs on and when the patient signs on. But really, so much of the work to have good telemedicine care is both sort of before and after. So, before the visit, we really need to make sure that patient have the appropriate technology, to have the right agenda setting, to sort of plan out the visit, sort of similar to how we approach in-person care when we might room a patient and then do a lot of things that we do to get patients ready for the visit. In telemedicine, I think the challenge is making sure that patients are able to even do the appropriate steps to get onto the patient portal and access technology. And similarly, after the visit, it's not just as simple as signing off and leaving the Zoom room. Early on, I was getting a lot of sort of feedback that patients are confused because they had a visit with a provider, the session ended, and their question is, what now? What happens next? Because I think even as we do the virtual visit, how we sort of figure out the patient journey and having the checkout process and the ongoing support be a part of that process, I think it's really important to really protocolize this. So, for example, now something we're working now is that what is the best way to check out for the patient. I think, for example, we are teaching our providers to let the patient know that, hey, the visit is ending, but you should expect a call from our staff to really to figure out the next step in terms of where you go for your labs, your tests, and when's your follow-up appointment, and what are the things that you need to do, and really to continue to offer them support throughout the whole process. So I think this kind of work to better sort of identify ways to optimize the patient journey for telemedicine is vitally important, and it's part of our ongoing work at Columbia and in probably many other places as well. Because I think long term, to create sustainable telemedicine models that are good experience for patients, really require us to really carefully walk through each of these steps and really to figure out what are the best ways to engage patients at each of these steps. So where are we headed? So this is data that came out in August. Is sort of an update from the Commonwealth Fund team looking at the telemedicine. Let's say the telemedicine as sort of as a pandemic sort of continued. So they showed that at again compared to the 2019 visit volume, there was that peak in April where 14% of the visit were on telemedicine, and overall things sort of slowly trending down, but are probably approaching a plateau. Larger practice sizes are maintaining higher level of telemedicine visit, probably for a variety of reasons, both scale and where their patient populations are. We sort of see this similarly. We probably are maintaining about 20% of volume as telemedicine visit, and that's something that we expect definitely will continue next year and probably beyond as well for a variety of reasons. I think partly because patients are used to it, it's also much easier to sort of give them the convenience of telemedicine visit when it's clinically appropriate. Obviously, a big part of this is how to sort of work with clinicians to define clinically appropriate scenarios and then to sort of optimize the patient workflow, as I was just mentioning. I think a large part of where telemedicine go will continue to depend on what kind of regulatory and coverage support will be available. In general, I think the direction is a positive one. We expect that the coverage to continue and expand, but we do need more sort of clarity on some of the policy and coverage aspects. CMS, I think, for example, in their proposed rules that are waiting to be finalized and which should be finalized shortly in December, they're proposing to continue coverage for most telemedicine services, and they're identifying mechanism to determine coverage and to really make sure that we have a smooth transition. They're sort of signaling that they want to figure out a way to continue to support telephone services, but still treating it as different than video visits. I think the one thing that many of us are a little bit disappointed in the proposed rule is that they did not say that they're going to broaden the original signing requirement sort of on a permanent basis, meaning the patient can be seen via telemedicine from their home, regardless of real hospital setting. CMS, I think, is sort of signaling that they think that that fix needs legislation. So a lot of the advocacy work is focused on to make sure that we, will have appropriate, legislation to really expand that, because that is really a requirement to be able to see Medicare patients at home via telemedicine services. You'll see, I think, in the news that they're sort of bubbling up that some payers are becoming more restrictive, quote unquote, for telemedicine service. But that's largely, I think, what they have done is that they're restoring the copay and co-insurance requirements for non-COVID visits. I sort of view this as really similarly, they're bringing telemedicine to a similar footing as in-person visits and sort of no longer advantaging telemedicine visits. And again, most of the conversations with payers that they do expect telemedicine to be continued. And some of my conversation with our payer partners is that they are looking for areas where they want to see telemedicine to have good outcome. They want to see that it doesn't sort of increase per utilization. But I think largely the evidence there has been positive. So I think we certainly expect that many commercial payers to continue to cover telemedicine, and it's something that we continue to press with them as well. I think the other big area of uncertainty is the state licensure governance requirement. Again, I think there's a lot of temporary licensure mechanisms and a lot of waivers during the time of pandemic. But long term, this is something that really needs to be worked out and require mechanisms such as interstate compacts or telemedicine licenses on a more permanent basis. There's a lot of competing interests in that space because I think, for example, in some states, local provider community and organizations may feel strongly about potential competition if patients can access specialist services out of state. And I think one other aspect to this is that if a patient is in Arkansas and see especially in New York, and there's something bad happened, what are the kind of things we need to think about from a patient protection malpractice perspective, because a lot of the current malpractice legislations and patient protection legislations are state focused and don't really consider how much telemedicine is being done. So a lot of those will need to be thought out and updated. But overall, I think we do expect telemedicine will continue to expand and will be a big part of how we deliver healthcare going forward. So just to summarize, this is my last slide. Telemedicine will remain permanent part of care delivery, and I think we'll continue to innovate and figure out how new ways to deliver telemedicine, both from a technology perspective and from sort of a workflow and patient engagement perspective. Technology will mature, and patients, I think, are increasingly accepting telemedicine as a routine way to access care. I think many of us ourselves probably have had telemedicine visit on the other side as patients as well, and it's really a pretty good tool to have. I think we'll need more evidence, and more evidence will emerge for how we can how to ensure that telemedicine delivers good quality of care. I'm sure there's papers in the pipeline already for how telemedicine compared to in-person care for quality and patient safety and clinical outcomes. I think another thing is that we'll need more ways to better integrate telemedicine as part of the care continuum. For example, if you're treating a patient for kidney disease, how often should they come in telemedicine versus in person? And there's probably some sort of a blend that can be optimized for each patient to sort of both make sure patient gets a benefit of access and convenience of not having to travel and find parking, but also to ensure that they get appropriate testing and radiology testing and labs as well. And then I think the final part is that it's very important as we do our telemedicine work to really think about where our most vulnerable populations are, to really engage them, empower them, and find new ways to do that so that we don't leave patients behind the digital divide. So I wanted to thank everyone. I think there will be questions coming shortly. I want to thank my institutions, NYP Columbia, my research from CBCH, to really giving a lot of support to allowing this work to be done. Thank you.